Hello, and welcome to this week's Independent Sage briefing. In the UK, infections, hospitalizations, and deaths are on the decline. So is the pandemic over? Well, not yet. As immunity wanes, especially for those over 65 and the most vulnerable groups, obviously we need to ensure protective measures are in place. We need boosters. It now looks like frontline staff, healthcare workers, and vulnerable groups, who actually make up 25 million in total, will receive another booster jab this autumn. But as we discussed in the briefing last week, vaccines and boosters alone cannot be the only measure. We need ongoing surveillance for new variants. We need to ensure that public and workspaces offer proper ventilation and other kinds of safety measures. We need to understand long COVID and potential treatments. We need new drugs and a new approach to community participation and communications for public health. Today, we're actually having a special public question and answer session to answer all your questions on a variety of matters, COVID and public health. We have a great panel of experts from many disciplines, including a new visitor, Professor Trish Greenhow, Professor of Primary Care Health Sciences in the University of Oxford. A great welcome to have Trish. I'm sure many of you know her from Twitter. But before we get on to that, I'm going to invite Dr. Kit Yates, our mathematical expert, to present us with the latest COVID number and trends. Kit.
Thanks, Anthony. So firstly, let me say it's a great pleasure to be back doing one of these Independent Sage briefings. It's exactly 9 months to the day since I did my last one when I took a break. So I'll get on with things, I guess. So today, make sure that the slides are working. Yes, they are. So the main messages are that prevalence is continuing to fall, although that may be plateauing a little bit, certainly slowing down in the rate of fall. But hospital admissions and deaths are also falling relatively rapidly following the falls that we saw in cases in the BA2 wave as that subsides. But we're seeing a couple of new variants that have been classified not in the UK but in Europe as variants of concern, BA4 and BA5, which are on the rise. So this is what I'm going to cover today. So vaccinations, hospitalizations, deaths, and then prevalence and variants in that order. So firstly, looking at vaccination data across the different nations of the UK, this is the proportion of people who are vaccinated, and you can see that roughly 20% of people across the home nations in the UK remain unvaccinated, and about 60% have received 3 doses, including the booster last autumn. So those numbers are remaining relatively steady at the moment. And if you look at the number of vaccines we're actually doing at the moment, then the numbers are really relatively low, especially in comparison to the peak that we saw back in December, which in some sense could be considered a missed opportunity, because we know that there are people who are not part of this spring booster campaign who may benefit. So, for example, people who are under 75 are not eligible for, or most people under 75 are not eligible for the spring booster, but we know some people would benefit, would get protection from that. Looking at younger people in particular, so this is people from 12 up to 17, we can see that firstly the 16 and 17-year-olds, we've actually achieved quite good first dose coverage there now across the home nations. So Scotland and Wales in particular up at 81%. Second dose is a bit lower down, but that's to be expected. Hopefully that will catch up soon. And then 12 to 15-year-olds, we're seeing first dose coverage over 50% in all the home nations, which is good news. But again, second dose coverage lagging a little bit behind. Now, these probably won't get as high as other adult age ranges, but we can hope that we can do that. And we've achieved over 50% in 12 to 15-year-olds. Conversely, looking at 5 to 11-year-olds who were, for a start, the vaccine was only made available in April, we're seeing relatively low rates of vaccination across the home nations. Now, this is partly a result of the fact that you have to wait 12 weeks since your most recent COVID infection in order to get the vaccine, which, given that we had a huge BA2 wave across February and much of March, continuing into April, it's not surprising that many people are not 12 weeks away yet, but also it's partly a result of the mixed messaging that's come from both the government and the JCVI as to the importance of this vaccine, this safe and effective vaccine. So this is a little bit disappointing, I think. Again, just to highlight, and we highlight this often, but there are also gradients of vaccination coverage by various demographic characteristics, but in particular deprivation. So you can see that the most deprived quintiles, the most deprived fifth of the population, have the highest levels of unvaccinated people and the lowest level of people who've received 3 doses, whereas the least deprived quintiles have the highest level of people who've received 3 doses and the lowest level of unvaccinated people. And what that means is that when the next wave comes along, different demographics will be impacted differently. In particular, it looks like most deprived demographics will be impacted hardest by that. Yesterday, we had the announcement from the JCVI of their autumn booster plans. So they have suggested a limited rollout for residents in care homes and staff, frontline health and social care workers, people who are 65 and over, and some adults, so between 60 and 64, who are clinically vulnerable. Again, the reason behind the JCVI's decision seems to be to mitigate hospitalizations and death, but nowhere in this autumn booster update do they mention long COVID, which we know is a big issue, and it can impact anyone, not just people who are at clinical risk and not just people who are over a particular age. In particular, we had a report come out last week from the Bank of England suggesting that long COVID is limiting the workforce. It's taking people out of work. And so this is just a reminder of some data we've seen before, but this is the number of people living with self-reported long COVID in the UK. So up at nearly 1.8 million people self-reporting long COVID. This was up to early April this year. Similarly, breaking that down by how badly impacted people have been, 600,000 say not at all, but over 1 million people say that this is limiting or reducing their ability to carry out day-to-day activities, and for around 350,000 people, it's doing that a lot. So personally, I think that this is not something that we should be ignoring in our considerations of whether we allow COVID to spread around the country, and also in particular in terms of our vaccination coverage. And you can see that as the waves that we've experienced have increased in size, the number of people who are reporting long COVID has increased in all 3 of these categories over time. So I think long COVID is something that should be considered by the JCVI if it's not already being considered. Moving on to hospitalization data, we're seeing, so this is just for under 18s to start with, we're seeing big steep falls in the number of admissions to hospital, which is really good news. This is for 6 to 17-year-olds in red and 0 to 5 in orange. So this is, of course, really good news, and we're seeing this following the falls that we've seen in cases. Similarly, for older age groups, we're also seeing steep declines in hospitalizations. Again, it's worth pointing out that these age groups that I'm comparing here are not of the same size, so 18 to 64, 65 to 84, and over 85. So the absolute numbers, these different colored lines, shouldn't be compared against each other, but really we're looking for the trend, and you can see that after very steep increases, earlier in April, we're seeing that hospitalizations are coming down, and to some degree that will alleviate pressure on the NHS, although we're still hearing about long ambulance wait times, unfortunately. Deaths are a similar story. This is deaths within 28 days of a positive test, so it's questionable how useful this metric is now, given that free lateral flow and PCR testing has been removed, but still by this metric we're at around 100 deaths a day, although it is coming down sharply, which is good news. And then looking at what we'd probably consider the gold standard data set from the Office for National Statistics and equivalent bodies around the UK, we're seeing slightly higher levels, but this is actually further back in time because this data is lagged. This is data by with COVID mentioned on the death certificate, so it looks a bit higher, but actually this cutoff point is a bit earlier, so this is a lagged indicator, even more so than within 28 days. So that's all good news that hospitalizations and deaths are coming down. Looking at prevalence, so the ONS released their weekly infection survey at 12 o'clock today, And so this is the percentage of people testing positive across the different home nations. It's roughly 2%, around 2% overall across the UK, which is still actually, quite high. 1 in 50 people infected. At earlier points in the pandemic, we would have considered this to be extremely high, but to some degree that impact of that has been mitigated by vaccines, of course. Looking at the trends, you can see that prevalence continues to come down, but actually it's the rate at which it's coming down is starting to slow. And it's too early to say perhaps that it's plateauing. Certainly it's not rising, but that may be what's on the cards in the future. Remember that this data as well is lagged by at least a week. So the survey that was reported today actually ended last week on the 13th of May. So we might expect to see more plateauing, and maybe even rises in future weeks in the ONS data. This is data from the Zoe symptom tracker app. It needs to be taken with a pinch of salt. This is people self-reporting COVID-like symptoms. But you can see actually, and they've reported today that they're seeing upticks in cases. They're suggesting this is increasing in incidence here, which Zoe is probably the most up to date, although not the most reliable data source that we have, because the ONS survey is lagged, and we can't rely on case data anymore now that free testing has been removed. So it's worth keeping an eye on that over the next few weeks. And part of the reason behind that potential plateau or rise might be variants. So this is the proportion of sequenced variant or proportion of sequenced PCR tests which are accounted for by different variants. And in particular here, I'm showing BA4. So BA2 is still dominant across the UK. I'm showing these two new strains, BA4 and BA5, and also this one which is currently growing quite a lot in America. And you can see that this BA4 strain is actually really growing quite rapidly. It's probably doubling every 4 or 5 days, its proportion of these sequenced cases. Now, cases are falling overall. So actually the rate of increase of BA4 in absolute terms is probably every 5, 6, maybe even 7 days. But we might expect, if these trends continue, that BA4 will become dominant across the UK early in June. And we might expect to see that if the absolute numbers of BA4 cases continue to rise, then we might expect to see an uptick and maybe even a new, what we might classify as a wave of COVID cases on the horizon. That said, there's a lot of uncertainty in these data. It relies on the fact that the samples are representative of the actual numbers of sequences across the UK, which isn't guaranteed, but early indications are that this is growing relatively fast, and it's something we need to look out for. Okay, so I'll just summarize by saying prevalence across all the UK nations is falling, but there's signs that it might be rising according to Zoe, or at least plateauing. Hospitalizations are continuing to fall, which might ease some of the pressure on the NHS. Deaths are also continuing to fall, but still what I would consider to be high, 100 deaths a day at the moment. Vaccination rate has slowed down and almost completely come to a standstill, and even with the autumn booster program, that might not pick up so much. And of course, we need to look out for these new variants that I've just mentioned. So I'll finish there, and I'll pass you back to Anthony. Thank you.
Kit, thank you very much. That BA4 business is a bit concerning. Obviously, we have to wait and see. And I travel a lot on trains, and I must say at the moment, only about 10-15% of people are wearing masks. So, there's a lot of potential for spread if that happens. Anyway, we're moving on to questions, and we'll come back to variants a little bit later, but we've got a whole lot of interesting questions that are going to come up, and I'm going to start with Alec Morley. Alec.
Hello, can you hear me okay?
Yeah, hear you fine.
Brilliant. So thanks for taking my question. So I recently met with some of the management of my university, and despite assuring me that they're open to anything in relation to improving safety, the majority of the suggestions I've made have been met with responses like they can't do X, Y, or Z due to guidance from the Department of Education. So I've suggested providing FFP3 masks free of charge for when entering examinations. But when I've raised HEPA filtration, they just said, well, it's not a magic bullet, and that in exams, people will be socially distanced. I'm dubious of the effect of social distancing given known aerosol transmission. So is there actually anything I can request for the community which aren't going to defy the Department of Education guidelines? And is there any evidence that I can give for, to provide such requests?
Thank you. That's a really good question and an important one because, you know, millions of people, hundreds of thousands go to university. And what you're saying is that, you know, you're trying to ask them about protection and you're not getting anywhere. Who shall I go to first? Stephen Reicher, maybe. What do you think about this? This is safety in the workplace for students.
Yeah, I mean, I'm surprised, and I would be fascinated to hear what Department for Education guidance is stopping people doing things, because I'm not aware that most of the things that we want to happen, like wearing masks, like decent ventilation, like HEPA filters and so on, are prohibited. As I understand it, what you can't do is issue punishments if people don't do things. You can't issue fines and so on, but you can certainly have very clear and strong guidance as to these things. Now, of course, I suspect that Anthony came to me not only because of my dashing good looks, but because of the COVID pledge, which we launched a couple of weeks ago. And the COVID pledge was precisely about this. And the COVID pledge is about workers getting together with management to do an assessment, to come up with a plan to keep everybody safe. And in particular, it's about ensuring people who are infected that they are able to stay at home and supported to stay at home. And that doesn't only mean saying things to people, it means giving people tests so they can find out whether they're infected or not. And of course, it means giving them the financial support they need to stay at home. UCU support the pledge and have asked all universities to support the pledge. So I think the first thing that you should do is talk and raise it in your local union branch and get them to go and negotiate with the university to make sure that the university takes seriously its legal, and I'll stress this, its legal obligation to keep people safe, because what we're asking for isn't anything extreme, isn't anything out of the way. It's simply that universities, like all workplaces, like all employers, take their legal obligations seriously. And secondly, that they follow public health advice, which is still, they might have taken away the obligation, but the public health advice is, number one, to wear masks in crowded spaces, number two, absolutely to stay at home if you're infected. And you would have thought that universities, which are places based on evidence and based on the best knowledge, would be following the best public health advice. So go to the union, get them to raise it with the university.
Trish, you've written a lot about ventilation and protection. And of course, you know, for Alec, he's basically saying that, you know, the universities are saying, well, advice from the Department of Education means that you can't implement any measures related to COVID. You can't recommend testing or provide testing or masking. But this isn't an educational issue. This is a public health issue. What's your view on this? And should Alec be going to the UK Health Security Agency or writing to the Chief Medical Officer? I don't know what they would say about this.
It's a very interesting issue, isn't it? I am not an expert in union law, for example. I mean, I'll hand over to Aris, I think knows more about that than I do. But I put in the chat a link to a peer-reviewed paper that we wrote a few months ago about what's the evidence, what's the scientific evidence for the measures that we as people who work in universities should take to protect both staff and students. And there were 6 things, and actually Alec knows these because he's said them already. And what he's worried about is that, you know, the powers that be in his university are not taking account of them. So let me give you those 6. The first is vaccination. Encourage everyone to be vaccinated unless there's a contraindication, and make it easy for people to get vaccinated. A lot of youngsters are actually feel that they're quite invulnerable, you know, oh, it's a mild disease if you're only 19, that kind of thing. If everybody's vaccinated, the spread in lecture theatres and things is going to be a lot less. Secondly, masks indoors. And of course, you know, if the prevalence is very low, the incidence is very low, people may say, let's have the windows open and let's not wear masks. But ideally, people should be wearing masks, and ideally they should be respirator grade masks. Thirdly, distancing. Now, Alec is absolutely right that if it's an airborne disease, which it is, then eventually, if you're in the room for half an hour, it doesn't matter how far away you are because it will have dispersed in the air. But it is also the case that if you're in the direct jet of someone's exhaled breath, if you're within a meter or so of them, you're more likely to catch it. So spacing people out is good. Then there's all the air cleaning, the filtering, either by sort of inbuilt filters, all those portable HEPA filters, and other ways of cleaning the air like ultraviolet. Then there's testing, but also isolating people who are symptomatic and or who've tested positive. And finally, supporting the clinically vulnerable staff and students to work remotely. So those are the 6 measures. How you get your university powers that be to actually take account of those, because the idea that there's guidance from the Department of Education that somehow gets universities off the hook for protecting the health and safety of their staff and students, there just isn't. But as far as I know, there has not been a legal case where someone's come to harm. And I'm now going to hand over to someone who knows a little bit more about union negotiations with authorities within universities.
Just before I come to Christina, who's got her hand up, I think, should Alec write to the, Dame Jenny Harries at the UK Health Security Agency or to Chris Whitty's office at, would they be putting that?
That's really difficult because I'm not sure that given the track record of certain individuals within UKHSA, I'm not sure that they would be wanting to, I think they would see it as interfering with decisions of universities, but I do think there is an extremely good scientific case for members of staff and students to say, we need to be safe at work. It is that simple. And there is a requirement on all employers and on all public institutions to protect the people who are working there and learning there and otherwise, in those organizations. So that is an overriding health and safety requirement. So at the moment, this idea that, we've got this guidance from the Department for Education, therefore we can put you at risk. I don't think that would stand up in court. But the question is, how do you fight it? And I'm not entirely sure of the answer to that.
Okay, thank you very much, Professor Greenhow. Over to Professor Christina Bargall.
So I just wanted to say something you could ask your university is, the good thing is that no one's talking in an exam hall, so that reduces the spread. But it's not just about how risky it is or how terrible the consequences of COVID. It's about what are the impacts of getting COVID right then. And during the exam period, you really do not want to get COVID and potentially have to miss an exam next week or affect your revision and so on. So actually, there's a high incentive for the university to prevent an outbreak, even if it's unlikely. And for that reason, I think they should be saying things like, actually, let's all wear a mask in the exam hall, let's put in a HEPA filter, let's do everything we can to reduce transmission, because it really matters for these 2-3 weeks that we're not spreading COVID. And I think that might be a better argument than talking about all the rest of it, because actually this is a very specific situation where, the benefits of not spreading it are obvious.
Thanks, Christina. Final thing is, several universities are represented here: Oxford, Imperial, UCL, Loughborough, Bath. Well, are our universities doing enough elsewhere? Is this just Alec's university? Or does anyone think they're working at a university that is taking this seriously? No one. So basically, most universities are failing in their public health responsibility. Right, that's message number 1. I don't see any hands raised. So we'll go on to the next question. Anne Webster. Anne. You're muted, Anne.
Here we are. Can you hear me now?
Very much. Yeah, we can hear you loud and clear. Thanks very much.
Thank you. This came out of an article I read at the beginning of the pandemic, so 2 years ago. is there much evidence of people catching COVID through their eyes? And I've been wearing glasses rather than my usual contact lenses since the pandemic began. Is this a pointless precaution?
That's a good question. We don't have an eye specialist. My daughter-in-law is an eye specialist, but I think we'll go to, who's got their hand up there? It was, well, Trish has, but I wondered about Deenan first. Deenan, you're a virologist. Would you say that there is even a small risk of getting infected from a droplet or aerosol spread through the eyes? And then we'll see what Trish says.
Yeah, no, well, hi, and thanks for your question. And I'm sure Trish will have chapter and verse on risk of spread. I think, I mean, yeah, there's always, mucous membranes are full are there available for infection, whatever sort of infection it is, and the cells in the eye may be susceptible, infectable. Clearly, it's not the major route. But of course, one never says never when you're talking about spread of respiratory sort of aerosol infections. Having said that, we do know that these shields over the face are pretty ineffective, that we see people still today wearing as pretty ineffective at preventing infection, whilst they may protect against direct droplet spread into the eye. They certainly don't prevent against aerosol spread. And therefore, my suggestion as another glasses wearer is not be reassured because you're wearing glasses.
Right. Trish.
Yeah, this has gone on for as long as the pandemic, hasn't it? You may remember the 32-year-old ophthalmologist from China who was the sort of whistleblower who raised the alarm that this could become a really bad disease. And he sadly and tragically died of COVID. And that, I think, got people thinking, well, this guy for his day job was peering into people's eyes and getting, and his own eyes were very close to perhaps being, coughed and sneezed on and all that kind of thing, coupled with the early theory that this was an exclusively droplet-borne infection. So the idea is that you would splash a bit of snot or something, saliva, into your eye. Now, if that is your model, if that's the mechanism, then of course eye protection, particularly for healthcare workers, was really important. And certainly my team were involved in a rapid review, which didn't really show much. Now, we now know that this disease is spread predominantly through the airborne route. And we also know, or at least we can be fairly confident, that it is the continuous exposure to viral-laden air of the internal lining of the lung. So if you're in a room for 2 hours, that's much worse than being in a room for 5 minutes, because you're breathing in and out air that's got viral particles in it. The size of, if you took your lungs and flattened them out and ironed them, stretched them out in 2 dimensions, they'd be the size of a tennis court. The surface of your eye is very tiny compared to a tennis court. So if the predominant way of catching COVID is exposure of your membranes to the air, that little membrane in your eye is not nearly as significant in terms of its vulnerability as the lining of your lungs, because they're so much bigger and that's where the air goes. So yes, if you were going to wear maybe swimming goggles or something to protect you from the air, but I wouldn't do that. If you're really worried, wear a decent respirator mask, and sure, wear your glasses or your face shield if you think someone's going to sneeze in your eye, which you'd be pretty unlucky. But that, as far as I know, and I looked it up recently, there has never been a single documented case of someone catching COVID from a splash in the eye.
Thank you.
But you can wear snorkeling goggles if you prefer, if that is your choice. They're very attractive these days. All right, thank you very much. That's a great question. Let's go to Ruth Rollin. Ruth, are you with us?
Hello, yes, I am. My question is about vaccines. We hear a lot about the world-leading UK vaccine programme, but what is actually happening? For example, I'm thinking about the fourth booster for under 75s, the autumn boosters, new tweaked vaccines for variants, and what about the great big stockpiles we built up? Are we giving away any surplus vaccines to other countries? Thank you.
Gosh, that is a big question. And I'm sure several of our experts will have something to say about some of those questions. So boosters for under 75s, autumn boosters, how are we going to tweak our vaccines for variants? And what about giving away surplus vaccines to other countries? And that touches on the whole issue of global vaccine inequity. Right. I think let's go to Danny Altman first. Professor Danny Altman is an immunologist and knows all about vaccines' effects on our protective immune system. Danny.
Yeah, I think you've covered lots of great questions there. So I'll try and cover them briefly in order. So the bottom line from me is that at the moment, I think vaccine complacency is one of our biggest enemies. So in this country, you'll often hear that we're doing terribly well because we've got a world-beating vaccine program. And I look at the data and I don't understand the pertinence of that comment anymore. We've got a population where at peak, 60% of us last autumn were at 3 doses. When I look at how much protection that buys us from Omicron or its subvariants, in real life, it's virtually zilch. Obviously, at the margins, as we know, yes, there's protection against really severe disease and hospitalization and death, but we still have a lot of people getting infected, and some of those will be serious infections. So of the pundits who are asked, so-called pundits, about that very restricted audience for the fourth boosts announced by JCVI, I was at the kind of cross end of the spectrum, saying we don't need it for a select group of the elderly and the clinically vulnerable. We actually quite desperately need it for all of us. Then the next part of your question was about different vaccines. I also think that to be doing kind of rolling mRNA boosts at short intervals in perpetuity is bad medicine and bad immunology and bad vaccinology, and not how we ever envisaged this. And there are so many better vaccine ideas waiting in the wings, and we need to be a little bit imaginative and go for it. And then the last question you had was about sharing vaccines. And yes, we need to do more, but it's a bit desperate because there's quite a short shelf life, and we've simply overstocked and hogged things that we probably won't have time to share properly. I'll leave it there.
Thanks, Danny. Aris, you're an expert on variants of the virus. Do you have any thoughts about where we should be heading with vaccine development?
I mean, we do. I think I completely echo Danny's points, right? We need to be thinking imaginatively about the long-term solution, the next vaccine, something that will be protective against transmission and really bring the infection and the pandemic to a true end. In the meantime, we have to be focusing on a better distribution of the vaccines that we have and equity, because there is both the moral case that the acute phase of the pandemic will not be over until everyone is as protected as they can be given our current technologies. And there is, of course, also the evolutionary argument that's with large parts of the world unprotected, that is a potential risky breeding ground for the generation of novel variants. So absolute focus on equity in the interim and huge research and investment in the vaccines of the future. We mustn't relax in that at all. We don't have the luxury to take the vaccines that we have for granted.
Yeah, thanks. I could chip in on the China situation is interesting because their coverage of their vaccine is actually better than in Europe and the UK. I think 86% of the Chinese population are fully vaccinated, but their elderly people, particularly the over 75s, have been very hesitant, presumably because they are vaccine skeptic or they don't really believe it and stuff. And so the Chinese are being heavily criticized for maintaining pretty brutal lockdowns. On the other hand, I think they must be scared that if they just open up, that, you know, maybe 1 million people will die or more, which is very easy in a population the size of China, because a lot of the most vulnerable are not fully protected. And I don't know if anyone has any thoughts about the comparison of the Chinese vaccine with the ones that we've been using, the mRNA ones, or not. This has a big effect on us, because the Chinese slowdown right now in their economy is having a big impact on the world financial system, and will continue to have that, and is contributing to inflation because so many goods are not coming out of China right now. But Dan, I mean, this is my question now. Danny, is the Chinese vaccine as good as Moderna, Pfizer, or even AstraZeneca?
Yeah, it's an interesting debate, isn't it? Because at the beginning, when we were all feverishly ranking all the vaccines, their inactivated vaccines always scored bottom of the league tables on neutralizing antibodies, T cells, and prevention and blocking infection. Now that we're in a very, very different world where many people have had an infection, we're looking at vaccines to mitigate severity of disease against oncoming subvariants. Having that kind of broad immunity, not just against spike, but against every protein expressed by the virus, is actually quite a good thing to have. So now they kind of, in some ways, come into their own.
So just on the issue of dumping vaccines or delivering them, or surplus vaccines, I believe there were many hundreds of thousands of vaccines that went to Africa, certainly last year, that had to be destroyed because they were very close to their expiry date. And we still have a situation where low-income countries have only achieved about 13%, I think, of them have been fully vaccinated. So that's 87% have not. I don't know, anyone got any thoughts about these issues of not only sharing vaccines, but more important, sharing the technology? So Professor, I was going to come to Professor Deenan Pillay. He was director of the Africa Center in South Africa for about 7 years. Deenan, do you have any thoughts about this?
Thanks, Anthony, and thanks for the set of questions, Ruth. On this, I look at another disease which really has swept the world and is in abeyance only now, 100 years after it came into humans, which is HIV. And the key, and despite a lot of efforts and vaccines, the key way in which HIV is controlled now, both in terms of preventing spread as well as treating those individuals who are unfortunately infected, are with antiretroviral drugs. And there's been huge advances, actually. Now the incidence globally is coming down, including in South Africa, which has the highest prevalence of in some areas up to 30-40% of the population infected. But the key thing that determined that was of the patent waiver on drugs and the ability of what we call generic drug manufacturers, both in South Africa and India and elsewhere, to be able to produce drugs at lower prices and then circulate those and distribute those drugs locally. And that has been the key determinant of our immense success there's been against HIV. Whilst it was, while patents were in the held by the pharmaceutical industry, then treatment was pretty much only targeted at Europe and North America. So there is a model. It's both about patent waiver, but it's also critically about local production. And we know that local production of vaccines can be done, can be rolled out. The expertise is there. So that would be my suggestion as a way forward.
So when I was at primary school, I remember a boy 2 years ahead of me who had a caliper on because he had polio. And I was in one of the first few years, two or 3 years of the Jonas Salk inactivated polio vaccine, which I got. And apparently when Jonas Salk was interviewed on the US television and somebody said to him, "Who owns the patent?" he said, no one owns the patent. Would you patent the sun? And you know, we all got it free because there was a public health spirit. But now everything's controlled by big pharma, and they are hoarding it. They have blocked it. And even the philanthro-capitalists like Bill Gates, who has given a lot of his money in the past to the COVAX movement and the Global Alliance for Vaccine Initiative, has defended the big pharma groups. Does anyone here want to defend big pharma in this regard, or do we think they should have made this pandemic patent openly available as was requested to the World Trade Organization by India, South Africa, Kenya, Eswatini, and numerous other states? Professor Martin McKee.
Yes, thanks very much. I think it is quite complicated. And if people have a look at what we recommended in the Pan-European Commission on Health and Sustainable Development, I think we need to look more comprehensively at the relationship between governments and industry to get into a proper partnership where the risks and the benefits are shared by both. Because at the minute we have a situation where, for example, the vaccines have been largely funded with basic science research from the public sector, from NIHR in the UK or the European Commission or from NIH. And then, of course, the government, we have paid that way, but then we're paying again a second time when the vaccines are being delivered. So we need to have that sharing of risks and of benefits, and we set out a number of proposals for that. So I think you need to look at it in the round, but we also need to look at research with purpose, as we call it. And that picks up on the idea that there are neglected tropical diseases. There should not be any neglected diseases. There should not be any groups of people. There needs to be a recognition that research has a social purpose as well, and not just about profits. So what I'm basically saying is we need a comprehensive assessment of all of these issues. It's not just about patent waivers. That may well be part of it, but we need to look holistically.
Yeah, but just to challenge a little bit on that, the World Health Organization asked the big pharmaceutical companies making the vaccines to share their technology over a year ago. And none of them have agreed to do so, none of them. And in the meantime, they have made hundreds of billions of dollars in profit. And it's difficult to square that with our experience with polio vaccination back in the 1950s, which was technologically more primitive, and yet they got it out, they shared it all, they didn't go for patents.
Or with insulin, for example, in 1921, exactly the same, where there was no patent on that. So I think that there clearly are things that can be done. I'm just simply saying that we do need to fix the system is broken. And I think the issue at the minute is there is a lot of vaccine around. That's less of an issue. There's an issue of distribution. There's an issue, a whole series of other issues around that. But I'm just saying, let's not just fix one bit of it and think that everything's done. We need a comprehensive assessment. That's all I'm saying.
Okay. Anyone else on this big subject? Deenan.
Yeah, just one other aspect while we're on vaccines, and this whole issue is also about the regulatory authorities and the approvals of vaccines. Now, and it is complex, as Martin has said, and of course the studies, the research needed to enable the Federal Drug Administration, the European Medicines Agency, and the UK now MHRA and other regulators to authorize vaccines does require very expensive clinical trials, and that's always been the quid pro quo with regard to industry supporting that and then wanting to get the money back as well. But of course, those trials themselves are not agnostic. The way in which those trials are developed are very carefully determined by industry in order to maximize the likelihood that a result will be forthcoming, which will both convince the regulators, but equally show a positive result. And we can see that the complications there in that the AstraZeneca vaccine, has not been approved by the Federal Drug Administration in the USA, but of course has been approved everywhere else, which goes to show that this is not just a standard academic approach. There are these nuances. So it just adds to the level of complexity with the rapid development of a drug or vaccine or whatever it is.
The other thing, of course, to say is that the mRNA vaccines are very difficult to distribute in low-income settings because of their needs on refrigeration and cold chain and the like. AstraZeneca is by far and away the biggest vaccine being used worldwide or up to date. So that's not,
which why local production is important.
Yeah, but it may not be as effective now with all these new variants. Quick one from Stephen Reicher, and then we'll go on to Anne, because she has a good question as well.
Here's a quick one. I mean, people quite rightly have pointed to complexity, but I think sometimes it's also important to return to simplicity and to reiterate a point which has been made implicitly, but I think is really critical. I mean, the biggest problem we face at the moment is the narrative that it's all over. And whenever anybody says that it's all over, they betray a breathtaking parochialism. And I think one of the points that needs to be made is anybody who says that, well, let them say it to people in China, and let them say it to people in North Korea, and let them realize that as long as it's not all over elsewhere, it's not all over here. So I think the simple point that really needs to be underlined is to say just how, not only how wrong, but how pernicious the it's all over narrative actually is.
Thanks, Steve. Okay, let's go to Anne McConway. Anne, are you with us?
Hello, can you hear me?
We can certainly hear you. We can't see you. Is that possible?
Oh, hang on. Bear with me.
There you go.
Can you see me now?
We can.
Okay, excellent. Hi, I'm one of the 1.8 million long COVID sufferers in this country, and I feel ignored by the government, Public Health England, and the medical profession. So my question is, how can we force the government to publicly acknowledge the scale and severity of long COVID, and to include it when talking about the risks of long COVID in public health messaging?
Thank you. That's an incredibly important question. Where would you fit yourself in Dr. Kit Yates? He gave that graph about not a lot, affected quite a bit, or a huge amount, or a lot.
Well, I got COVID in October last year, and I was in bed, unable to lift my head off the pillow for 5 months. And since then, I've tried every treatment going, and I now am able to move around the house a little bit more, but I haven't worked, I don't drive. It's completely ruined my life.
So you're in the really severe category. Okay, yeah. So how are we going to acknowledge the scale and severity of long COVID? I think we'll go to Benita first, Dr. Benita Kane.
Hi, Anne, and thank you for sharing that. And I'm really sorry to hear that you've been so poorly and it's affected your life in such a way. And, all my sympathy and empathy goes out to you. It's $1 million question, actually, and one I've been asking myself for a long time, because this is, in my view, a public health catastrophe. And what we are going to have is a more chronically ill population, much of which are working age and have families. And also, when you look at the scale of the number of children involved, you have carers who are taken out of work. So from an economic perspective, rather than anything else, it is catastrophic. And I think that is starting to be recognised, for example, in comments made by the Bank of England this week about a dwindling workforce. How do we get our voices heard? I think the data is starting to speak for itself, and we've seen Kit's figures on the numbers with every wave increasing. There are a number of groups lobbying for this to be recognised more broadly. I think one of the challenges is that acknowledging long COVID doesn't really fit with the living with COVID narrative. And that is really, really problematic, because there's lots of people who want COVID to go away and the pandemic to be over. And actually, long COVID is a really ugly reminder that we've still got a huge problem on our hands. So I don't have the answer, but I would say that we just continue to speak out. I think patients, patient advocates and groups are really, really important to tell stories. And hopefully, once there is a critical mass of people, it cannot be ignored anymore.
Thanks, Benita. Trish, would you tell us a little bit about locomotion?
Oh, yes, I can do. I mean, I'd also like to extend my sympathies to the caller. And I think her story is at one end of the spectrum of how long COVID affects people. So the definition of long COVID is that you've still got some symptoms 4 weeks after you first got unwell with COVID. Now, that actually is not that uncommon. I think about a third of people who get COVID aren't quite better by 4 weeks. Most of those are going to be better by 12 weeks, but there is quite a significant fraction who remain unwell for months and months and months. And some have been unwell for more than a year. I think it's 700,000 people in this country have been unwell with long COVID for more than a year. Now, there's all sorts of reasons why that is. After many viral illnesses, glandular fever, flu, whatever, a proportion of people feel exhausted, find it hard to get back to work, and sometimes are really quite kind of wiped out. So the question with long COVID, is it just because so many of us have had COVID, or is there something particular about coronavirus? Anyway, what's the locomotion study? The locomotion study, the LOCO, it stands for long COVID, and then I can't remember what motion stands for, but it's something to do with designing services that support people with long COVID, and government gave some money to set up long COVID clinics. One of the problems is that because there's so many people with long COVID, most people haven't actually been seen in a clinic. So the question is, well, what can people do for themselves? What can GPs do? What can generalist physicians do? That kind of thing. So the long COVID study is a study of the patients attending 11, I think it is, of these long COVID clinics. It's led by Manoj Sivan in Leeds and Brendan Delaney from Imperial. And the idea is that one of the components of it is a quality improvement collaborative where we work with patients to capture the patient experience and ensure that all aspects of care are evidence-based, and also to work on access for people who are waiting for an appointment. How do we fast track people to specialist investigations and treatment? So that's an ongoing study. There's also another big study led, I think, by Ami Banerjee in London called Stimulate ICP, where they're testing different investigations. Do you want to scan every part of the body, or do you want to kind of only do scans if you're specifically looking for something? And also different interventions with things like antihistamines, all sorts of things. So there's a lot of research going on, and at the moment it's pretty wide open. If you said to me, what's the perfect way to manage someone with long COVID, I wouldn't be able to answer that, and I'm not sure that anyone can. But there is a lot of research going on, and we're hoping to be able to report back, in a year or so with the first results.
Thanks very much, Trish. I'll come to Danny. Danny Ortman. I almost said Danny McNamara, but he plays for Millwall.
Wouldn't play for Millwall.
I want to know about the immunological basis of long COVID, what the latest is. And there's a second question on this from a Sally Boliakos, who says, what's the link between microclots and long COVID? Given there seems to be a lot of clot danger, why is there still no diagnosis and treatment for long COVID being provided? But that may be outside your area.
Yeah, well, let me try and pull together a lot of things, and I know Benita's involved in this as well, and can probably add. So, I'd endorse everything that's been said up to now. So my sort of opening sort of header would be, somebody who's been involved in long COVID and its research throughout. And I'm not a very kind of melodramatic person. and yet I feel more and more alarmed, not less alarmed, as the pandemic has gone along. As in, every time I thought we'd reached peak numbers, they've grown higher. Every time we thought that vaccination would lead to long COVID being a thing of the past, we find that it's breaking through in massive numbers in times of even milder disease, so-called milder disease, in time of Omicron. So every time we thought it was going away, it's kind of got worse, not better. Every time I thought I had hopes that maybe it would be a 6-month story or a 12-month story or an 18-month story, it isn't. It's not going anywhere anytime fast. And if you look at what we can learn from long SARS, if I can call it that, it's probably not going to go anywhere fast. It's probably going to be with us for years. So that means, to me, it looks like the biggest challenge to our kind of daily public healthcare activity, on top of things like rheumatoid arthritis, sort of common chronic disabilities that are an enormous draw on our society, on our healthcare spending, on our clinical workforce. And so my sort of simple answer would be, I do think we imagine we're trying. I think policymakers imagine they're trying, researchers imagine we're trying, and we're not even scraping the surface of it because it is so enormous. So I think we've got to make our voices heard at the COVID-19 inquiry. And then the last part of your question was, so the immunological research at the moment is that there's a lot of juicy papers coming out that put little biomarkers out there in terms of immune subsets or autoantibodies. The idea of it is a partly autoimmune disease. And I'd also put the microclot observations to some extent in that category as well. So we're in a slightly tantalizing situation at the moment, I guess, as I'm saying, where we've got lots of observations here, there, and everywhere. And we really need the momentum and the oomph to put them all together into big studies and meta-analyses and work out what the hell is going on. So that's my not very satisfying summary.
No, that's great. Before I come back to Benita, there's another question that's kind of linked to this in immunology from Chris Gales. He says, do we know how long T cells from vaccination remain active and effective? And how should this influence further boosters? Because I've been, as you know, there's been quite a lot of stuff about does T cells not working very well underpin long COVID, but presumably long COVID is a spectrum of diseases which have different kind of causes. Any thoughts on T cells and vaccination and long COVID?
So shall I do 30 seconds and then pass to Benita? So obviously my whole life has been T cells, so I couldn't be a greater T cell aficionado. And even I'm stumped for how to fly the T cell flag on this one, because a lot of people are publishing papers saying that T cells are your secret weapon, rescuing you from the current wave and from Omicron. I'm not sure if I see hard evidence for that. I think we're sort of on a knife edge in terms of our protective immunity, and T cells aren't really seeing us through. They may be a small part of the story of why we're not dying in the same way as people were in 2020, and whether T cells have something special to say about vulnerability to long COVID. I think the jury's completely out. I've seen no strong evidence, but I'll go to Benita.
Thank you, Danny. I'm not going to comment on T cells, if that's okay. Just coming back to Anne's story, I think one of the frustrations is we know that there's money being put into research. There are research trials that have been set up, that clinics have been set up, but this was all done at a time which was well over a year ago. And things have moved on so dramatically in the world of research since then that we simply have not in any way begun to think about catching up. So what we know from the research that's coming out week to week, day to day, is not being translated into any treatments for patients like Anne who are struggling to live their lives. And the wonderful studies that are ongoing, like Stimulate ICP and Locomotion, won't report for another 12 months at least. And so that's another 12 months of chronically ill health for people who have had their lives turned upside down. And it feels to me like our research machinery needs to change, that we cannot have the same model for randomized controlled trials that we've historically had for something like long COVID. We need something more agile, something more rapid, maybe real world studies that can be done in parallel, but that requires national coordination, investment, funding. And we just simply are not getting the will from the right people to invest in this. And it's how we lobby for that change.
Thanks very much, Benita. Right, I want to just come on to the last question that we can do at the moment because we're almost at time. This is from Simon Cotter. My understanding is that all the major variants of concern, such as Alpha and Delta, have sprung directly from the original strain from Wuhan. However, as international travel continues to open up, I would expect these variants to displace the Wuhan strain almost entirely or completely. Therefore, would that mean that we would be more likely to see further recombinant variants or subvariants becoming the most likely threats going forward rather than a pi variant? Well, that stumped me. Aris.
Yeah, I can give it a go. I mean, you know, in the first phase of the pandemic, we did see this sequential replacement of dominant variants. And now we have the Omicron with its subvariants, which is quite different in its dynamics to what we saw before. We're getting the BA4 and the BA5 versions of Omicron now dominating, which are themselves descended from Omicron itself rather than the initial sort of deep splitting lineages of the virus. But not all of those deep splitting lineages have gone away. I mean, Delta is not completely extinct, although it's been largely replaced by Omicron. And the more the lineages diverge from each other, the more scope there will be for recombination to play a role in the future evolution of the virus, because up until this point, if two almost identical viruses were to recombine, we wouldn't really know the difference because they were that similar to begin with. But if two very distinct viruses recombine, that actually opens the door for much larger sort of stepwise changes in the further evolution of the virus. So we may see recombination between distinct lineages and sudden shifts in immunological characteristics play a bigger role in the future evolution of the virus.
Thanks very much. So we're not over, but we are over for today because we're at time. Thank you to all members of the public. Actually, I've got 3 other questions we haven't answered, so I might carry those over to the next session. We really appreciate all your questions and the participation and support of people. Thank you to all the panel for their insights. Next week, we've got a really important session lined up, which we'll be discussing the strains of the pandemic upon the NHS and broader questions about how we're going to protect and strengthen our National Health Service. So do look out for our Twitter announcements and do send us questions like you always do. We'll see you all next week, same time, same place. Stay safe. Keep well. Bye.